All right, so first we'll go over we're going to go over urinary tract infections. So we'll go over lower UTI first. And you've probably heard this before that women are more prone to a UTI because they have a shorter urethra, and the urethra is really close to the rectum, which is not great by design, but here we are. Also, women that are postmenopausal or have low estrogen levels are going to be at risk. People that wear synthetic underwear, anybody, your patients with bowel incontinence, anybody with diabetes, because bacteria loves sugar, anybody with indwelling catheters. So the trend now is not to keep catheters in for a long time because of that, because it causes UTI. Neurogenic bladder, like we talked in spinal cord injury, stroke, and Parkinson's in older adults, are all going to be at risk for a lower UTI. The most common pathogen you're probably going to come in contact with in your lifetime is E. coli. Here are the three conditions that comprise a lower UTI. So cystitis, which is probably the UTI that you're familiar with, urethritis, so that's inflammation of the ureter, and then prostatitis, so that's inflammation of the prostate gland. Now you can remember the symptoms by the mnemonic FUNWISE, and it's anything but fun, okay? So F is for frequency, U is for urgency, N is for nocturnal, meaning people with UTIs have to get up in the middle of the night to pee. They'll have nasty smelling urine. W is for weak stream, and this is for prostatitis. I is for intermittency. S is for straining, and E is for emptying incompletely. So people feel like they void in small amounts when they have like a UTI. The UA, you're going to have to know this. You're going to have to know some of these, like what are you going to see in a UA if somebody has an a UTI? So you're going to see you're going to see bacteria. You're going to see positive leukocyte esterase, and it's also considered pyuria. So that means there are white blood cells in the urine. Now you're also going to see white blood cells in the urine. The urine will have nitrates. So nitrates indicate that E. coli is in the urine. You might see red blood cells in the urine of a UTI, and the pH is either going to be very high or very low. So you'll have to know that information. Now, with older adults, you probably already know they present with confusion, new incontinence, nocturia, and they'll have tachycardia because anybody that is under stress has tachycardia, hypotension, and tachypnea, and fever equals urosepsis. So that's why you have to watch them so carefully. Anybody that is pregnant and has an upper UTI needs treatment as soon as possible because it could result in preterm labor. Okay, treatment includes antibiotics like penicillins, cephalosporins. So if anybody is taking these drugs and they get hives, then you're going to stop the medication. If they're taking the quinolones like ciprofloxacin, you're going to tell them to report ankle pain because that can damage the Achilles tendon. They're going to be at risk for sunburn because they're going to be have photosensitivity. Now, don't confuse photosensitivity with photophobia. Photophobia is when light hurts your eyes. Photosensitivity is when your skin is more sensitive to the sun. Anybody on antibiotics needs to report watery diarrhea because they could have C. diff. Phenazopyridine is a urinary analgesic. There's a couple things you need to know about this. It's going to turn their urine orange, but to evaluate if it's working, you're going to ask the patient if the pain is gone because it's a urinary analgesic, so it'll stop that pain, the burning. So it's really a good drug for that. Now, with your client education, everybody needs to finish their antibiotics, not just when they start to feel better. Everybody needs to empty their bladder every 3 to 4 hours. Everybody needs to void before and after sex. Everybody needs to drink a lot of water. You can tell the client to get some cranberry-based products to inhibit bacterial adhesion. Cis baths are okay. Hot water bottles are okay. this is the big one, wipe from front to back, not the other way around. And don't wear underclothes that retain moisture. Okay, that's very important. Now,
I
with
got a
an upper
question,
UTI,
Miss. I got a question, Miss Corn.
yes,
So with diuresis, that is not one of the symptoms for UTI, as
or
far as like
UTI,
you have.
no.
Okay,
Uh-uh.
because diuresis and frequency is two different things when it
Yeah,
comes.
so frequency is kind like you feel urgency and you feel like you have to go, but you're voiding in small amounts with the UTI.
Gotcha.
Yeah.
And the diuresis when you go a lot. Okay, makes
Yeah,
sense.
like yes, you have a lot. Okay, so with an upper UTI, we're talking about acute pyelonephritis. And one, you know it's acute because one kidney is involved versus chronic with two kidneys, okay? Now, so what happens is E. coli travels up the ureter and gets into the kidneys, and then it makes these pus pockets. Okay, so it's a kidney infection of the renal pelvis. Usually it's young women because they're not voiding before and after sex. It has the same symptoms as UTI: dysuria, hematuria, frequency, burning, itching. But here's something that's different than UTI. They have what's called costovertebral angle tenderness. So CVA tenderness, the provider would just like give a little punch to the back, the percuss or palpate the back, in the flanks, and they'll be very tender. Okay, and they'll have nausea, fever, chills, sinus tach, maybe a low blood pressure. Older adults confusion. See, all the same signs as a UTI, except they have that costal vertebral angle tenderness. Okay, there's a chronic version. You really don't need to go into a lot of detail with this. I'm just gonna, the reason is the chronic version is gonna go through the same stages. It ends up in chronic kidney disease, and I'll talk about that later. Okay, so this is both kidneys. So they're gonna have chronic, and it could be due to like taking too much Advil during your life, having kidney cancer, repeated UTIs. People with HIV or diabetes may be more prone to it. But this is what you do for anybody with like a UTI or pyelonephritis. Have them drink 2 liters a day to avoid dehydration. They can take their pyridine, which turns your urine orange. And then for chronic, we won't even go into that. And for pyelonephritis, you take antibiotics for a very long time. Okay, I'm going to talk about glomerulonephritis. Now, I have nephrotic syndrome on here, but I'm not going to go over it. And the reason is ATI recently took it out of the adult ATI. It's in your textbook, but it's not in the adult ATI because you're going to learn about it in 120. And I don't want to overburden you. I'm trying to like lessen this load for you right now. So you are going to learn about nephrotic syndrome. I'll leave it on here. I'll leave it within your resources in case you want to come look at it then, but it's not going to be on your exam. Okay. Acute glomerulonephritis is seen in children, usually young adults. And usually after some type of infection, the body forms an antibody antigen complex and it attacks the glomerulus. Okay. So your signs and symptoms you can remember from the mnemonic had strep. So they're going to get hypertensive, which is unusual in small children. They'll have positive ASO anti-streptolism, and that's a lab. And the reason they have that is because this usually happens after a strep infection. D is for decreased glomerular filtration rate. And you have to know what that means. Glomerular filtration rate is 125 milliliters per minute. That's like the normal. Okay. It decreases when the kidney function goes down, and it goes back to normal when the kidney function gets better. Okay. They're going to have diffuse abdominal pain. They'll have swelling in their eyes and face. They'll have tea-colored urine. It's also described as smoky and rusty. They'll have a recent strep infection. they'll have an elevated BUN and creatinine, and they'll have proteinuria, mild. Okay, so what happens is the glomerulus gets damaged and it starts letting blood, red blood cells and protein leak into the urine, which aren't usually there. That's what gives it the tea-colored urine, and you shouldn't have protein in your urine. And that, because they lose protein, they're going to have a low albumin, and that's why they get swelling in the face and eyes. Okay, so that's important to know. The labs, the GFR is decreased. There'll be low albumin in the blood. The BUN and creatinine is increased, and the GFR is going to be decreased. The only way to definitively diagnose it is with a kidney biopsy. So
I
with the
got a,
kidney biopsy, yes.
I got a question. So with the glomerulus, when you said it's infection, or is it infection in the glomerulus?
Okay, so it's not actually like they have an infection, right? And then for whatever, it's like an immunological problem. The antibody it forms like this antibody complex that destroys the glomerulonephritis,
Oh,
the
okay.
glomerulus. So
So
it
it
gets
messes
in.
with the blood vessels in there?
Yes,
Okay,
yeah, it makes them more permeable.
gotcha.
So the protein in the red blood cells are leaking out and they go into the urine.
And they're not
Okay.
filtering like they should?
Yes, that's true.
Okay.
Yeah. All right. So with the kidney biopsy, the kidney, I'm going to mess this up. The liver gets 150 mLs a minute. I think the kidney gets like 120 mLs a minute. So that's just to point out that it's very vascular. So you have to get coagulation studies beforehand because you don't want your patient to bleed out. Hold pressure for a long time after, and no heavy lifting after. Um, the treatment depends on the signs and symptoms. Now, I'm going to go over oliguria and anuria because that's part of acute kidney injury and chronic kidney disease. But the typical fluid restriction for a patient that has kidney disease is you take the 24-hour urine output, you add 500 to 600 mLs, and that's how much they can have today. So today, my total output in 24 hours is 2,000 mLs. So tomorrow, I can have 2,500 to 26 mLs the next day. Okay, you're going to monitor the weight daily. They get steroids in immunosuppressants, and they could get plasmapheresis. But anybody that has a lot of edema needs to go on bed rest to help the fluid remobilize. All right, here are the diagnostic tests. I kind of already went over the UA. And so you're going to need to know like protein you would see in glomerulonephritis, red blood cells you would see in glomerulonephritis, um, leukocyte esterase, you would see an infection. Nitrates, you would see an infection. And WBCs, an infection. pH high or low, you would see an infection. The creatinine clearance is kind of synonymous with the GFR, so it's the same thing. So if somebody has kidney disease, it's going to go down. As the kidney gets better, it will creep back up. I think you guys know the BUN and the creatinine. If you're ever asked what is the most sensitive, the best lab is the GFR to determine kidney function, but we don't really do that a lot. So the creatinine is the next best, and the BUN is less than the creatinine, but we would still look at that. All right, kidney biopsy I talked about. So you're worried about bleeding after. So you don't want hypertension because they're going to bleed out. You don't want them to move around a lot. They're going to be on bed rest. With the KUB, this is just a plain film, and they would do this if somebody had like renal calculi. So ask if they're pregnant and make them take off their jewelry. That's what the nursing interventions are for that. The CAT scan of the kidneys. This has contrast dyes, so make sure you're checking the BUN and creatinine beforehand. The creatinine is the most sensitive. Make sure they have good urine output, and make sure if they're on metformin, it was held 20 hours before and 48 hours after. They are going to need, fluids after to flush out their kidneys. MRI, same thing. It has contrast dye, but you don't have to ask about an iodine allergy because it uses a different kind of dye, but it's still toxic to the kidneys. A renal scan is safe to do for the kidneys. A pyelogram or a cystogram that has dye, but it is not the cystogram. It's not absorbed by the body, so you don't need to worry about that. Okay, now we're
So,
getting into it.
oh, never mind. I
Yeah,
saw it. No, I was just
right.
about to ask for the metformin with the contrast, but it was on there. I saw it.
Okay, yeah. So that's always going to be a proctor topic. I mean, HI is big on that, right? So kidney stones, the other name for that is nephrolithiasis, and they're made in the kidneys, and they can be found anywhere in the urinary tract system. Urolithiasis are stones that form in the urinary system, like the ureters of the bladder. It doesn't really matter where they're formed, okay? They're still going to wreak havoc. So you can be at risk because of your job, like as a nurse, because if you get dehydrated, you might be at risk for having a kidney stone. So the symptoms are, it's very painful, actually. People have told me that have had babies that kidney stones are more painful. So they're going to be in a lot of pain. So they're going to have tachycardia, tachypnea, diaphoresis, um, and rusty, smoky colored urine. If the kidney obstructs the ureter, like their urine, they become anuric, that's a medical emergency because it could cause a kidney injury because the urine now is going to back up. That's called hydronephrosis, and that could result in a kidney injury. So what are you going to do about it? You're going to give them morphine or ketorolac. You can encourage them to drink a lot of fluid, encourage them to walk to pass the stone. They're going to need a lot of IV fluids and a lot of fluids to flush it out. You're going to strain the urine to find the stones in it to see if they pass the stones, but you're going to send them for analysis to determine what kind of stones they are. Okay, so the risk factors include having a family history, um, eating certain foods, which I'll talk about, being obese, dehydrated, and some digestive diseases can make you more prone. And immobility makes you more prone. All right, this right here, the type of stones, calcium oxalate is the most common stone. So I'm thinking if you were going to get something on NCLEX or Proctor, it's going to be about calcium oxalate. Okay, the adverse effects of kidney stones, again, if this stone here obstructs the urine outflow, this is hydronephrosis. And this can cause great injury to the kidney, and they may need to get a nephrostomy tube. So that this person's going to have to pass that stone or get it blasted. So patient teaching with your calcium oxalate stones, this is what I think you'll most get tested on NCLEX. So they need to avoid spinach, Swiss chard, black tea, chocolate, cocoa, pecans, and limit sodium. Okay, that's the kind of foods that they have to eliminate in their diet. Then this extracorporeal shockwave lithotripsy, that's like shockwave to break the stones up. Okay, so after the procedure, you're going to expect flank bruising and hematuria. So monitor for dysrhythmias because they do use shock waves and the patient can get a dysrhythmia. So monitor for like syncope, dizziness, palpitations. The patient complains of a racing heart. Watch for that. Strain all urine to determine if the stone passed. And they may be put on medications like an alpha blocker like tamsulosin or calcium channel blocker like nifedipine. Okay, you have to know a lot about BPH, okay? Lots of questions on ATI about BPH. All right, it's a result of normal aging in males. So what happens is the smooth muscle and the epithelial cells just multiply. So it's like they just grow, and it impairs the outflow of urine, and it can result in prostatitis. Okay, so your risk factors are being male at birth, um, drinking alcohol, caffeine; those are considered urinary stimulants. Um, Leading a sedentary lifestyle or being obese with a BMI greater than 30, eating the standard American diet, a father that had BPH, metabolic syndrome, and diabetes and heart disease. Now, prostate cancer is not a risk factor for benign prostatic hypertrophy because it's benign. Your signs and symptoms. Well, now you have fun pissed because they're not having fun if they have this. Okay, so they have the frequency, the urgency, the nocturia. They can be up 5, 6 times a night. Poor stream, or inability to start the stream, a sense of not being able to empty their bladder completely, straining, pain on urination, dribble, and dysuria. Okay, the patient can get kidney disease if the urine continues to back up into the ureters. So the test they'll get, a UA, is going to show WBCs, bacteria. The BUN, if they have, and creatinine will be elevated if they do have kidney disease. Now, to diagnose it, they're going to do a digital rectal exam, but that has to be done after they draw the prostatic specific antigen blood test. That's the blood test they're going to draw um, to see if they have BPH or prostatic cancer. Okay, so people that are going to have this can't ejaculate for 48 hours. They don't have any food restrictions, and they should start getting it at age 50. UTI can make it elevated, and anybody with a level greater than 4 needs to be investigated. All right, medications, they can go on DHT lowering medications and finasteride, which may take 6 months to see results. Also, tamsulosin. In this TURP, okay, you got to understand this. So they may go for TURP surgery, and it's like they do a cysto and they like flagellate, so they like rotor-rooter, so to speak, the prostate right here. Okay, so when they come to when I walked in the recovery room, it was like Groundhog Day, because they come in and they're on post-op care, and they have like this, we call it a Murphy drip or a continuous bladder irrigation. Okay, so they would have this going, because you have to do that, because when they do this rotor-rooter, all these little pieces, like little clots, need to flush out of the bladder. Otherwise, they're going to get clotted, and the urine's going to back up. Okay, so for post-op care, this is what you're going to do. You have to maintain the catheter's patency. So these are 3,000 milliliter bags. They're really heavy to get out and put on, but you put 2 of them. Okay, so I'm going to clamp this one and I'm going to run this one. And you run it so the urine is a rosé color. Okay, you never want to see bright red blood in the catheter after this surgery. And your object is to make sure that this stays clear. Okay, so it's a 3-way catheter, and it has a balloon with 30 to 45 mLs, and it's taped lightly to the leg to maintain traction. Now, this is what happens. They come into the PACU, they wake up, and they start trying to climb out of the bed because they feel like they have to pee, and because this is a bigger catheter than you're used to. And they keep doing that. I gotta pee. You're gonna hear that over and over again. You're gonna monitor the INO, keep urine a light pink color, and you adjust the color by increasing the rate of the continuous bladder irrigation. Your urinary output is your return, how much you emptied in the bag, and the amount of solution that you put in. So if I put in like 1,000 mLs of that solution and I drain 1,500 from the urine bag, that means the patient put out 500 mLs of urine. Okay. Bladder spasms could indicate retained pieces of prostate causing obstruction. So you're going to irrigate with a 50 ml piston syringe and call the provider if you're unable to dislodge the clot, because they could get the kidney injury if you don't. They're going to be at high risk for DVT. And the urine should be amber in about 3 days, no heavy lifting, and no sex for 2 to 6 weeks. So all this is really important, the signs and symptoms, the risk factors, and especially the Murphy drip. Okay, I'm going to go over renal function. So the best way to talk about kidney disease is talk about what the kidney is supposed to do and what happens if the kidney can't do it. So the kidney is responsible for our acid-base balance. So if the kidney cannot maintain that function, we're going to get metabolic acidosis with Kussmaul's respiration. So that means the pH is going to be low and the bicarb is going to be low. And how do you treat that is fix whatever's causing it. But if it's really severe, the patient's going to have dialysis to change the blood back to normal homeostasis. W is for water removal, so look for signs of fluid overload if the kidney's not working. So you'll have like the crackles, the tachycardia, tachypnea, shortness of breath, and that pink frothy sputum, okay? So what you're going to do about that is increase the head of the bed to high Fowler's first, then put on O2. If the patient is not anuric, in other words, the patient is still making urine, they'll get furosemide. If the patient is not making urine and they have pulmonary edema, they're gonna need dialysis. And they maybe get put on a fluid restriction, especially if they have chronic kidney disease. E is for erythropoiesis. So if the kidney is not working, can't make the erythropoiesis or the erythropoietin, they're going to get anemic and they're going to need to take Epigen. So monitor for BP and headache. T is for toxin removal. So like people with kidney disease are going to be more prone to have adverse effects from medications. The high BUN and creatinine, and can't remove it from the bloodstream, so that leads to uremia. And they're going to have a low GFR. So monitor for signs and symptoms of uremia. I'm going to go over that. They're going to need a low protein diet to prevent uremia and confusion. B is for blood pressure control. So the kidneys help us maintain our blood pressure. So if they can't anymore, then the patient's going to get hypertension, which is treated with ACE inhibitors, calcium channel blockers, and beta blockers. And remember, your ACE inhibitors and ARBs can increase your potassium, and that's important to know because most patients are on ACE inhibitors that have kidney disease, but they also can't get rid of potassium in their body. So you have to watch that. E is for electrolyte balance. So people with kidney disease are going to have high potassiums because they can't put out urine, high phosphorus, low calcium because calcium and phosphorus live in an inverse relationship, high magnesium, and high sodium. Yeah, so for high potassium, you're going to use the Kxalate, the insulin, the dextrose. And for high phosphorus, people with kidney disease are put on high phosphorus foods or they're given phosphorus binders. For the low calcium, you're going to encourage calcium in the diet. And for magnesium, avoid magnesium containing antacids because they can't get rid of magnesium. Vitamin D activation is done by the kidney, so that's going to result in low calcium. So again, you're going to encourage high calcium diet or adding calcium foods to their diet. All right, so all those findings I just talked about, you are going to see in the oliguric stage of acute kidney injury, the oliguric stage of acute glomerulonephritis, in chronic kidney disease, in chronic pyelonephritis, and glomerulonephritis, and polycystic kidney disease. So in uremia, your patient is going to be anemic. When you have a high BUN, that makes the red cells lyse. So that's, and also with uremia and kidney disease, the kidneys aren't making erythropoietin, so the patient's going to be anemic. So they're going to have pallor, lethargy, and breathlessness. The platelets don't work properly, so they're going to be prone to bruising, petechiae, bloody nose. The skin color in uremia is like a tannish gray yellow color. We call it sallow, SALLOW. They're going to be really itchy. They're going to have anorexia, nausea, vomiting, and diarrhea. They're going to be confused. That's why we give them low protein so they don't get confused. And then also they can get heart failure. Because of the low calcium and high phosphorus, they can get pathological fractures because they're going to be prone to broken bones. So with acute kidney injury, there's rapid loss in renal function. So it happens quick and it results in a high BUN and creatinine and a low GFR. All right, so there's three different types of causes. There's pre-renal causes, and this happens because something happens that makes the kidney not perfuse. So this is like diarrhea, diuretics, dehydration, so vascular reasons, intrarenal, insult to kidney, okay? Nephrotoxic medications, scleroderma, contrast dye, vancomycin, gentamicin, all those meds, NSAIDs can cause insults to the kidney. And post-renal is renal calculi and BPH, okay? Phases, you have your onset, you have your oliguric stage, which is 1 to 3 weeks. You don't have to remember like this part of it, but you do need to know like the signs and symptoms of the oliguric stage and the treatment. So it's just see the symptoms in a wet bed, and the symptoms are going to be the same as uremia. When the kidneys start getting better, they get so excited they diurese like 10 liters a day. So you're going to have to replace fluids and monitor potassium. Okay, with chronic kidney disease, the two most common causes are hypertension and diabetes. So chronic kidney disease affects every body system. So look at the wet bed again and signs and symptoms of treatment. There's 5 stages. You don't really need to know like all the 5 stages. I'm just going to tell you a couple things. Stage 4 is when you tell your patient they have 3 choices. You can choose dialysis, transplant, or death. And stage 5 is when, usually you can't get a transplant that quick. So they would go on dialysis, or if they wanted to die, then, you would arrange for hospice. Okay, so here are the symptoms that are in brown are symptoms of uremia. So asteristics is nerve flapping, ataxia, encephalopathy. So uremia is neurotoxic and it irritates the mucous membrane. So they're going to have stomatitis, gastritis, better. So these are all the signs and symptoms of uremia. Okay, so hemodialysis and peritoneal dialysis. So with hemodialysis, they need some kind of access device. So this is not a permanent one. It's called a permacath, but it's not really permanent. It can be short term, but it can be used long term as well. And just goes in the subclavian or internal jugular. So the rule is only the dialysis nurse touches this. You cannot draw blood from this. You cannot hang blood in this. You cannot, monitor a CVP through this. Only the dialysis nurse. You can't have a lot of manipulation with that. Okay. So with hemodialysis, you want to weigh the patient before and after. You're going to give a lot of heparin when you give dialysis. So don't let the patient have any other procedures 4 to 6 hours after dialysis so they don't bleed out. Make sure you have protamine sulfate on hand. Know the patient's dry weight, which is the weight after dialysis. Monitor for hypotension, disequilibrium. This is from pulling off too much fluid too fast. They can get confused and have seizures. So you would just slow it down. They can get hypotension during. Okay, AV fistula or graft. This is a kind of internal device, vascular device. They take, like for the fistula, they take an artery and vein and sew them together. Okay, and then over time, this artery really blows up. I got a picture to show you. But what's important for you to know is if they have one of these devices, they cannot have the blood pressure IV on that side, no labs on that drawn on that side. You're going to feel for a thrill and you're going to listen for a bruit to make sure that it's patent. You want your patient to do range of motion on that arm and do your neurovascular checks. They shouldn't wear a watch on that arm and don't carry heavy items. They need to keep clean, and then don't sleep on the graft site. So this is what a mature AV fistula can look like. It's kind of nasty, huh? Yeah, so do your neuro checks. And then with peritoneal dialysis, this is like a good choice for people who don't want such a restrictive diet, and that they have good like cognitive ability. Okay, so it's contraindicated with anybody that has peritoneal, that has adhesions in their intestines, like they had surgery a long time ago and now they have adhesions, or if they have polycystic kidney disease. And that makes sense because if you poke something in their abdomen, you might hit one of these kidneys. They're like 10 pounds each. All right, the candidates for peritoneal dialysis, they have to be able to take care of themselves. And it's a good choice for people that can't take anticoagulants. So when you're giving peritoneal dialysis, there's something called the fill, and that's when you fill the peritoneal cavity with the fluid. Then you dwell however long the provider wants, like 30-minute dwell. So you leave the fluid in for 30 minutes. Then you drain it. That equals 1 PD exchange. So you fill 1 to 2 liters over 20 minutes, okay? And the dwell is specified by the provider. Then when you drain, that's called effluent or outflow, and it drains by gravity into the collection bag. So your complications include, it increases protein loss. So patients that undergo peritoneal dialysis have to increase protein. It can cause peritonitis. Peritonitis is a very serious condition. We're going to talk about it in a lot of the conditions we talk about in this series, so to speak. But they're going to complain of tenderness in their abdomen. They're going to be guarding. They will have a fever. They may have a rigid or board-like abdomen. They'll have a high white count and a temperature. Okay, and they can perforate their bowel from having peritoneal dialysis. They can gain weight. So if you're having trouble draining, okay, you want to make sure you check for kinks, roll the patient side to side, and then make sure the patient isn't constipated. Oh yeah, peritonitis, okay. Very serious complication. So the first sign will be FE cloud, the effluent would be cloudy. And then you're looking for fever, high BC, board-like abdomen, tenderness, and guarding.
I got a question, Ms.